The following podcast is part of a certified educational activity titled Navigating Biologic Therapy in CRSwNP from Patient Selection to Response Assessment. Access the entire activity and complete the post-test at peerview.com/FVW860. Downloadable slides and practice aids are also available.
Hello, and welcome to this town hall activity on navigating biologic therapy in chronic rhinosinusitis with nasal polyps. I'm Katie Buchheit from Brigham and Women's Hospital, and joining me today is Dr. Joseph Hahn from Old Dominion University.
Thank you, and glad to be here, Katie.
So, in terms of setting the stage and understanding chronic rhinosinusitis with nasal polyps and the shift toward targeted therapy, we're going to talk about CRS with NP, a chronic type 2 inflammatory disease of the upper airways, with symptoms consisting of nasal congestion, facial pressure, loss of smell, and polyp formation, which often recurs despite intranasal steroids, surgery, or systemic corticosteroids. We're going to discuss the clinical challenge that a significant number of patients with CRS with NP have type 2 inflammation driven by cytokines such as IL-4, IL-5, and IL-13, associated with a really significant symptom burden. Patients have frequently relapses, impaired quality of life. It's often associated with comorbid asthma. Conventional therapies can offer limited durability in some instances. And right now, there's really an evolving landscape. Biologic therapies can provide targeted treatment for patients who have uncontrolled disease. And this really represents a shift toward precision medicine and long-term disease control. So our goals for tonight are to augment your knowledge on the pathophysiology, clinical presentation, and disease burden of CRS with NP, equip you with strategies to identify appropriate candidates and integrate biologic therapy into treatment plans, and to provide guidance on assessing treatment response to biologics and adjusting therapy as necessary while addressing patient concerns. And we're going to have a town hall question time to discuss modern CRS with NP care. Each session will begin with some question and answer featuring questions previously submitted by your peers in the treatment community before tonight's event. Questions are grouped by topic, and you can keep asking as we go along. We'll take your questions and answer them in the chat as time allows. So the first question we're going to review is related to pathophysiology. How can clinicians differentiate between type 2 inflammation and other endotypes in patients with CRS with NP? So, Joe, how do you think about this?
Yeah, and I think, this is a really good question because, the question is if you have nasal polyp, what's driving the inflammation? And understanding what's driving the inflammation helps you, provide the appropriate and targeted treatment for that patient with nasal polyp. I would say most of the nasal polyp are type 2. Sometimes some nasal polyps are non-type 2. And I think, one of the ways that and I think a lot of experts kind of differentiate CRS with nasal polyp as type 2 is looking to see if there's, comorbid disease that are associated with nasal polyp, like allergic rhinitis and asthma. And actually another way, through the EPOS and the Euphoria, we were trying to define, what exactly is type 2. We initially started off with a blood eosinophil greater than 300. We're now saying it's 150. And then we're also saying if the total IgE is greater than 100. Now, with that being said, that's the lowest threshold for deciding if something has type 2. It doesn't necessarily mean that those markers, those biomarkers are driving the nasal polyp. So I think that's one thing to kind of, for the clinicians to kind of think about, get these blood work, look at these biomarkers. It helps you understand that it's type 2, but it may not be the driving force.
Yeah, I totally agree with that. And, in the allergy immunology space, we are seeing a lot of those patients with comorbidities. A lot of patients will present us really for asthma management. And, we learn from them that they have nasal polyps or, work with our otolaryngology colleagues to kind of collaborate and make that diagnosis. And those patients, as you said, tend to be really type 2 high. So I think that is something certainly for allergists to look out for. And we think about doing the endotyping the same way often that we'll do, or very similar work up to what we do for our patients with severe asthma in terms of looking for blood eosinophils and IgE levels. That can all be very helpful. So moving on to the next question is actually, this is fits in right here, talking about comorbid asthma. So what is the prevalence of comorbid asthma in patients with chronic rhinosinusitis with nasal polyps, and why is its presence particularly significant in managing this condition? So comorbid asthma is quite common in the patients that we see who have CRS with NP. Upwards of 60% of patients with nasal polyps and type 2 inflammation can present also with comorbid asthma. And, I think there's a number of reasons why it's relevant in managing the condition. One, it's a sign the patient has type 2 inflammation that's really driving both the upper and lower airway disease. And two, we can think about using treatments that will help both in terms of managing the patient's upper and lower airway symptoms at the same time. And, we certainly see in patients who have nasal polyps who undergo surgery, often associated improvements in their asthma control with that. Certainly targeted biologic therapy can be efficacious for both nasal polyps and asthma in any of our patients.
Yeah, and if I can add something to that, Katie, is, I think the reason why, understanding that the patient has comorbid asthma is because, a lot of times, we as otolaryngologists, we'll do nasal polyp surgery, and we'll think that with nasal polyp surgery and medical treatment, that usually is enough. But if they have asthma, it helps us predict that those patients with asthma are the ones more likely to have the polyps recur and need revision sinus surgery and have the polyps come back more quickly. And so these are the patients that I think are really good candidates for a biologic. And based on studies that we've seen, those patients with asthma and nasal polyp tend to do really well with biologics in general.
Yeah, that's a great point about thinking kind of asthma as a prognostic marker for how they may do and offering that information to the patient up front. I like that. So to define chronic rhinosinusitis with nasal polyps, we have cardinal symptoms, and we expect patients to have more than 2 of these symptoms for 12 or more weeks. And that includes mucopurulent drainage, nasal obstruction, facial pain, pressure, fullness, or impairment in sense of smell, so hyposmia or anosmia. And this is paired with objective findings of nasal polyposis. So either endoscopic inflammation, you see nasal polyps on endoscopic exam, or radiographic findings that are consistent with nasal polyposis. We see here the inflammation of the paranasal sinuses. And we know that for the majority of patients that we see in the United States, and type 2 inflammation is really driving disease in many and most of those patients. So we know that patients with chronic rhinosinusitis with nasal polyps have dysregulated epithelium and have overproduction of alarmin cytokines such as IL-25, IL-33, thymic stromal lymphopoietin or TSLP, which can then drive T cell polarization and also ILC2s to produce the canonical type 2 cytokines like IL-4, IL-5, and IL-13, which can further drive this allergic type inflammation or type 2 inflammation. It can lead to class switching of B cells to IgE producing cells, which can activate mast cells and basophils. It can drive production of tissue eosinophilia, and then also mucus responses, airway remodeling, inflammatory cell recruitment as well. And, we talked a little bit about endotypes with the last question. In this study done by Whitney Stevens at Northwestern, they looked at the inflammatory profiles of actually hundreds of patients who had chronic rhinosinusitis. And we see that in the patients who had chronic rhinosinusitis with nasal polyps on the top right, that the majority of those patients had at least some component of type 2 inflammation. About 2/3 of them had purely type 2 inflammation. And then there were many patients with type 1 and type 2 mixed endotypes, or type 2 and type 3 mixed endotypes. So again, we see that 87% of the patients had at least some type 2 inflammation. And this is really quite relevant in terms of driving the disease that we're seeing in the majority of our patients who have nasal polyps. In patients who have chronic rhinosinusitis without nasal polyps, type 2 inflammation is certainly an important driver of that as well, but we see more evidence of type 1 and type 3 inflammation in those patients. So, in terms of the prevalence of type 2 inflammatory comorbidities, we certainly focus on asthma. Up to 65% of patients with nasal polyps also have comorbid asthma in some studies. The prevalence of asthma is much lower than that. In the general population, it's around 8.5%. And CRS with NP is associated with adult onset asthma. So, usually the story is that I was healthy as a kid and then I, developed asthma and nasal polyps in adulthood rather than childhood onset asthma. The CRS with NP and asthma endotype is associated with more severe type 2 inflammation compared to patients who have CRS with NP alone who don't have asthma. And up to 26% of patients who have CRS with NP have comorbid nonsteroidal anti-inflammatory drug, or NSAID exacerbated respiratory disease, also called aspirin exacerbated respiratory disease. And those patients have a triad of nasal polyps, asthma, and respiratory reactions to aspirin and NSAIDs, and can have a really severe phenotype of nasal polyps and also severe asthma associated with this.
Katie, so here's a question, one of the questions that we got, and I think this is a great question for you. Why do you think some patients continue to experience polyp recurrence and persistent symptoms despite multiple surgeries and corticosteroids?
Yeah, so this is a really interesting question. I think what this gets at is that, for most of our patients with nasal polyps, the driver is immunologic. So while surgery, I think, has a whole bunch of benefits that you can really comment on more than I can, um, the underlying inflammation and drivers of inflammation don't necessarily go away just by having the polyp tissue removed and sinuses opened up. So even after surgery, we do see that in many patients disease can recur, and again, that's because it's not necessarily an anatomic problem or a plumbing problem. It's really an immunologic problem that doesn't necessarily go away with surgery. And I think with corticosteroids, they offer temporary benefit, but as soon as they wash out and you're no longer taking them, again, the inflammation returns, and we see kind of that immunologic driver of disease causing disease to recur.
Yeah, and I was wondering if I could say it in a way that would maybe resonate with otolaryngologists. I think the way you explained it is exactly right. And for ENT doctors or otolaryngologists, when we think about chronic sinusitis, we know that with sinus surgery, certain types of chronic sinusitis really gets cured and resolves completely with surgery. But chronic sinusitis with nasal polyp is exactly like you said, is immunologic disease. It is truly a chronic disease, so a chronic persistent disease, just like asthma. So once you have these nasal polyp, it won't go away with surgery. And a lot of otolaryngologists think that if you have sinus surgery, it'll all go away, just like certain types of sinusitis. But for nasal polyp, I really don't think it does. It really doesn't go away, and that's why it recurs, and that's why a lot of otolaryngologists are surprised. But once you have that mindset, like you explained so clearly and nicely, I think then it's no longer a surprise when the polyps come back after surgery. And so when we think about chronic sinusitis with nasal polyp, it is not surprising that the polyps can recur. And depending on what type of nasal polyps you have, it can range anywhere from 10 to 40% in patients. As you heard earlier, there are patients with comorbid asthma where the polyps rate come back much more quickly. And we know that patients with aspirin triad come back much more quickly. This is a study from 2017 where they, based on nasal endoscopy, saw that the recurrence rate came back from 35%, 38%, and 40%. Now, this study was done prior to the age of biologics. So, in the age of biologics, if you look at papers, the recurrence rate for these polyps still are high, but not as high. We know that there are different types of procedures that have been published, such as using draft 3 or what we call endoscopic modified Lothar procedures. Those are used, especially in the frontal sinus, to decrease the recurrence of nasal polyp. Now, there is a procedure called reboot in which they strip the mucosa. I don't think that's something that's commonly performed in the US. And in fact, most people say that in the era of biologic, why use a reboot surgery? Because it is a very, I think, a destructive mucosal process. So we try not to do these procedures. And I think, as you heard earlier from the slides, that a lot of the patients with nasal polyp really is a type 2 driven nasal polyp disease. And it's not surprising that these patients, because it's a chronic process, that there are recurrence of symptoms and recurrence of nasal polyp after surgery. Next, we're going to talk about who, when, and why identifying biologic therapy candidates. So I'll turn it over to you, Katie.
Okay, so for our first question on CRS with NP, we're going to talk about clinical indicators. So this is a great question. What clinical indicators do you consider essential when deciding whether a patient is a candidate for biologic therapy in CRS with NP? So Joe, what do you usually look for?
Yeah, I think what we look for are has the patient had some conventional treatments or standard treatments that they have failed. I think the workhorse for nasal polyp is topical steroids. We'll use systemic steroids sparingly, but we don't like it. In patients who have not had surgery, we would consider them having at least one good sinus surgery. If the patient still has polyps come back, depending on how quickly they comes back, how severe the nasal polyps look, that's when we start looking at, considering biologics. So we call it either uncontrolled or severe.
Yeah, no, I would agree with that. And, we often will look for, really, again, symptoms that are associated with being uncontrolled, right? So even if we, have a patient where, there's been some recurrence after surgery, but they're still feeling really good, we don't generally consider biologic therapy unless they need it for something like asthma in that case. So, we're looking for patients who have really severe day-to-day symptoms, blockage, impairment in smell, ongoing mucus production, and then related impairment quality of life. So impairments in their sleep or overall productivity or just how they're feeling day to day. And then, certainly in the allergy world, we're thinking a lot about comorbidities. So certainly if a patient has nasal polyps and severe asthma and they really warrant a biologic for severe asthma, we'll consider that to be a clinical indicator as well. So in terms of determining when to initiate treatment with biologic therapy, selection of biologic drug and sort of monitoring of effectiveness is something that we think about again in, as Joe said, in patients with a diagnosis of uncontrolled severe chronic rhinosinusitis with nasal polyps. So they've tried the typical first-line therapies, topical steroids, plus or minus surgery, sometimes also with systemic or oral corticosteroids. We think about comorbidities, again, if they have really severe asthma or NSAID exacerbated respiratory disease and the consequences related to that, sometimes a biologic will be indicated. It's important to assess that type 2 inflammation is highly likely. And we talked about some of the biomarkers that we look for, but that would include, blood or tissue eosinophilia, as well as serum IgE being elevated. And, we have good discussion with the patient on options, different perspectives and risks. And then patient can decide on whether or not they'd want to, pursue treatment with something like a revision surgery versus biologic drug. And then we'll select a specific biologic based on patients' comorbidities, what we see in terms of their biomarkers. And generally for patients who have both chronic rhinosinusitis with nasal polyps and comorbid asthma, it's helpful to collaborate with an asthma specialist to ensure that we're choosing a biologic medication that is most useful for both their treatment of their nasal polyps as well as asthma. So from the updated EPOS and Euphoria criteria in terms of indications for biologic treatment in CRS with NP, we look for patients who have bilateral polyps who've previously had endoscopic sinus surgery and then meet 3 of the following criteria. So as we talked about, looking for evidence of type 2 inflammation, here's where we look for the tissue or blood eosinophils as well as the elevated serum IgE. Need for systemic corticosteroids or a contraindication to taking systemic steroids. So if you have a patient who's taking multiple courses of steroids per year or is on long-term maintenance daily oral corticosteroids, we know that there are significant toxicities associated with long-term use and cumulative lifetime exposures to systemic corticosteroids. So we want to mitigate that and, consider biologic to reduce the reliance or need for systemic corticosteroids. We're looking for patients who at baseline have impairment in quality of life. So in the EPOS Euphoria guidelines, they suggest looking for patients who have a SNOT-22 of greater than 40, patients who have smell loss, and certainly thinking about biologics in patients with comorbid asthma, especially those who have regular need for inhaled corticosteroids. And then, this I think is a very useful stepwise treatment algorithm for management of chronic rhinosinusitis with nasal polyps, based on expert opinion. In patients who have really refractory disease, those that don't respond to first-line management with intranasal steroids, for the majority of patients, the recommendation is that they undergo endoscopic sinus surgery. This is really important to set expectations with the patients in advance that also comes with really diligent post-operative management. So saline irrigation, steroid irrigation, or some sort of intranasal steroid therapy applied pretty diligently after surgery to help prevent the polyps from recurring. That is sort of the approach in the majority of patients. There is a minority of patients for which they have a contraindication to surgery. They have very poorly controlled asthma despite being on standard therapy, or they have oral corticosteroid dependent asthma, or for some reason they've declined surgery after a shared decision-making process, that for those patients you'd consider initiating a biologic therapy upfront. But again, the majority of patients will plan to undergo sinus surgery with good post-operative management. In the patients who have surgery and their polyps recur, there are a variety of approaches to be considered after surgery, one of which is biologic therapy in patients with recurrence. Certainly, there may be settings where a patient would instead choose to have revision surgery or other approaches, such as a burst of oral steroids, steroid implants in their sinuses. And for some patients with aspirin or NSAID exacerbated respiratory disease, you could consider aspirin desensitization. So I think this is really kind of useful framework for thinking through when to use biologic therapy. So for our next question, we're going to talk about biologic eligibility. So actually, this is a great question for you, Joe. Should every patient with polyps, refractory or not, be candidates for biologic therapy?
That's a great question, because I think it kind of depends on who you ask, right? So I think if you ask surgeons who like to operate, they would say that if a patient has refractory nasal polyp, they should undergo sinus surgery. Now, other people who don't operate, if the patient has refractory nasal polyp, certainly they would think about starting them on a biologic, and then if they're not getting better, consider a biologic switching. But more studies are starting to come out now where we have patients where we started them on a biologic, the patients initially got better, but then the symptoms and the polyps still persisted. So we've kept them on the same biologic, performed surgery, and kept them on the same biologic after the surgery, and the polyps surprisingly have not come back. So I think there's still more data that we need to collect, but I think the answer to that question may vary based on whether or not you do surgery or not. So
Yeah, I would say even from an allergy perspective, if I see a patient, who comes to me first for whatever reason, and I see that they have nasal polyps or I really suspect it, I will always, certainly refer them to my otolaryngology colleagues, because I think that, there are many patients who do great after surgery, and kind of thinking through, what are their comorbidities, what do their biomarkers look like, and what else do they have going on? Are there any contraindication to surgeries, anything like that, is an important kind of discussion to have with them. And, I think for many patients, surgery does often make sense, at least to try, one good endoscopic sinus surgery. And that really, I think, ties into the next question, which is, do patients have to go through rounds of intranasal steroids and or surgeries before they can receive a biologic? So I think the answer to the first part is definitely yes. We wouldn't consider biologic therapy in someone who hasn't tried a good course of intranasal steroids with proper technique for application at all. And the question about surgery, again, I think this is really the same question as before. Generally, in someone who's had surgery and had recurrence, I think at that point it is very appropriate to consider biologic therapy. There are some times where you would consider it before surgery, again, in someone with really severe asthma or a contraindication to surgery, for example.
Yeah, and to kind of add to that, there are different types of intranasal steroids that people can use. I think the one that's most commonly used and very easy to use is a steroid spray. But we also have in the U.S. we have EDS fluticasone, which is another way of delivering topical steroids for the nasal polyp, and I think it delivers the topical steroids a little bit better. And then we also, if those who've had surgery, and there are studies now, even in those who did not, where you could deliver steroid implants into the sinus cavities or nasal polyp area and reduce the nasal polyp. So I do think that it is and it also certainly I would say sometimes patients may want to try the nasal surgery and they may never want to have surgery. So those patients certainly can be a candidate for a biologic, but I do think that there are different types of delivering topical steroids, and the efficacy can vary based on the different type of intranasal steroids.
Yeah, that's, I think, a very, very important point for sure. So, escalating intranasal steroid therapy can make a big difference in some patients. So for the next question, if a patient has chronic sinusitis without evidence of polyps, could a biologic be considered in the future for these patients if they're exhibiting signs of type 2 inflammation as well?
Ooh, so I actually, so this is one of the studies that I kind of helped lead, looking at a biologic in chronic sinusitis without a presence of nasal polyp, that don't have nasal polyp on nasal endoscopy, but you're pretty sure based on comorbidities, different biomarkers, that they have type 2 inflammation. And the study, we did present some of the data, and it does show that biologics are helpful and effective in these patients with chronic sinusitis without nasal polyp, as long as they have type 2 disease. And that makes sense, right? Because if someone has a type 2 inflammatory, like you said, an immunologic disease, and these biologics target the type 2, it makes sense that these patients would get better. Now, the question then arises, should you be using a biologic in these patients who don't have nasal polyp and have not had surgery? And I think that's kind of where it gets a little bit murky. But I think I'm glad they asked this question. I think the evidence does show that if the patient has a type 2 CRS without nasal polyp that you can't see on nasal endoscopy, but clearly has a type 2 inflammation that's driving the sinusitis, certainly a biologic, which is a T2 biologic, will be effective in these patients.
Yeah, I think that was a really interesting study, and I would say that for patients with really severe asthma who have chronic rhinosinusitis, even without nasal polyps, if biologics indicated for asthma, it may actually help with some of their sinonasal symptoms. So that's something certainly to follow and watch in those patients if they need the biologic for asthma anyway. So the next question is about comorbidities. How do comorbid conditions influence your decision making when selecting biologic therapy? So I'm happy to start with that one. In allergy immunology, we use biologics for a variety of conditions. We use a whole slew of biologics now at this point for treatment of severe asthma. We're using, there's now 2 FDA-approved biologics for treatment of chronic urticaria, both omalizumab and dupilumab. We use it for eosinophilic esophagitis. We use it for atopic dermatitis. So oftentimes when I see patients who have chronic rhinosinusitis with nasal polyps, and I think, hey, you would benefit for biologic therapy for treatment of your nasal polyps, I always ask and sort of think about the other chronic comorbid conditions. Because if I can use one treatment to treat 2 different problems, that patient will really appreciate it. And it certainly, in terms of resource utilization, makes sense from that standpoint. So I actually, spend a lot of time, certainly with the sort of comorbid asthma patients who are the most common ones that we see. But we see, I see a lot of patients who have nasal polyps and eosinophilic esophagitis, or nasal polyps and, atopic dermatitis, where we want to, choose one drug that can target multiple problems.
Yeah. Kate, I don't think there's anything more I can add. That was great.
Perfect. All right, we'll move on to the next question. So choosing among options. So if a patient qualifies for multiple biologics, what's the best way to determine which one to try first?
Ooh. Are you going to answer this, or you want me to try it?
Do you want to start? Go ahead. You start, and I'll finish.
I would say, I think, like you said, the comorbidity is one of the first things I look at. The other things that I look at are biomarkers. So, someone with high blood eosinophils, I would certainly consider choosing an anti-IL-5. If they have elevated levels of total IgE, I would consider a biologic that really targets the IgE. And so those biomarkers are a factor. And then one last thing is a patient's symptoms. And so now we know that there are certain biologics that improve certain symptoms. And so if patients have a loss of smell and they want a quick response improvement to the loss of smell, certainly a biologic like dupilumab would be a biologic I would choose. So it is multiple factors. One other factor is that I think is an issue which is not a big differentiator right now, but could be a big differentiator in the future, is the frequency of injections. And patients don't like to get frequent injections. When they're miserable, they do. When they're not so miserable, then it becomes a bigger issue.
Yeah, no, I think those are all really important points. I think, as we discussed, comorbidities are important. Certainly, I think that there is more and more emerging efficacy data that I'm actually going to show shortly that, may help us kind of understand which to choose first. But then there's a lot of patient-specific factors, such as, yes, how often they're willing to inject, or if they need to come into clinic for whatever reason to get their injection, how often they're able to come into clinic. Those things can all make a big difference. So those, I think, are great points. So, looking at what to consider, we think certainly about other indications as we talked about. So dupilumab has actually many indications now: atopic dermatitis, asthma, eosinophilic esophagitis, and then, prurigo nodularis, which we don't see a ton of in patients with CRSwNP, but is an important itchy skin disease. Patients with eosinophilic chronic obstructive pulmonary disease, chronic spontaneous urticaria, and then also bullous pemphigoid. For omalizumab, which is also approved for treatment of CRSwNP, it's also approved for allergic asthma, chronic spontaneous urticaria, and now food allergy. And then mepolizumab is approved also for asthma, EGPA, which I think is a really important comorbidity to consider, especially in patients with high eosinophils, and then hypereosinophilic syndrome. So this can, do some of the job in helping to choose specific agents. So let's review a case of when a biologic might be used earlier in the treatment algorithm. So we'll talk about Sarah, who's a 34-year-old woman with asthma, which was diagnosed when she was 15. But she's really had chronic symptoms of nasal congestion, postnasal drip, and anosmia for the past 4 years. She has frequent sinus infections requiring antibiotics multiple times per year. She does have a family history of allergy and ATP. And comes to us because she's had persistent nasal congestion, facial pressure. It's not getting better with oral steroids or nasal sprays. She's also had a recent increase in asthma exacerbations, requiring more frequent use of both her rescue inhaler and oral steroids. She had polyps, which were identified in her nasal cavity on CT scan. And in the past year, she's had 2 courses of systemic steroids for asthma exacerbations, and she's hospitalized once for an asthma attack. So in terms of her current treatment, she's on an ICS/LABA for asthma, intranasal corticosteroids and saline irrigations for nasal polyps, and then she's taking antibiotics as needed for recurrent sinus infections. So, really poorly controlled asthma and nasal polyps in this particular patient. So, when we're thinking about the mechanism of action of this targeted biologic, where it comes in here, we've talked a lot about type 2 inflammation. We see that there are a variety of type 2 targets of these biologics. So just kind of starting from the top, tezepelumab, which has been studied for nasal polyps. It's not, as of right now, FDA approved for treatment of nasal polyps, but it's been studied for it. It's approved for asthma. It targets TSLP, specifically, which is pretty far upstream in this inflammatory cascade, there are a number of agents that target either interleukin 5 or its receptor, that's benralizumab, and mepolizumab, which are also approved for asthma. Mepolizumab is approved for nasal polyps. And then depemokimab, which we'll talk a little bit more about, that is an ultra long-acting anti-IL-5, which is been studied for both nasal polyps and asthma. Dupilumab, which blocks the interleukin 4 receptor alpha. It can block signaling of both IL-4 and IL-13, has impacts on a variety of cells. It can block class switching to IgE. It can, inhibit mucus response, certainly can lead to some restoration of the epithelial barrier and has a variety of immunologic effects as well. And then omalizumab can block, omalizumab binds IgE and can prevent it from activating mast cells. So in terms of comparing these available biologics for treatment of CRSwNP, just to kind of briefly summarize some of the systematic reviews that are available, omalizumab can lead to significant improvements in clinical and patient-reported outcomes and has been shown to be more effective than placebo in patients with high eosinophil levels, and also in those with a history of surgery, prior surgery for CRSwNP. Dupilumab led to significant improvements really across all the outcomes that they studied, including a reduction in need for surgery and reduction in need for use of systemic corticosteroids. And the efficacy has been shown to be independent of baseline eosinophil and IgE values, as well as a variety of comorbidities, including comorbid asthma, allergic rhinitis, NSAID-exacerbated respiratory disease. Mepolizumab was shown to significantly reduce need for surgery and lead to some improvement in symptom severity, regardless, again, of the presence of AERD or comorbid asthma. And very recently, there's been some initial data presented about a phase 4 study called Everest, looking at a head-to-head study of dupilumab versus omalizumab for patients with CRS with nasal polyps and asthma. And it showed that dupilumab was superior in terms of reduction in nasal polyp size, patients' ability to differentiate smells, so some of the objective smell measurement, also superior in terms of reduction of nasal congestion or obstruction, loss of smell, reduction in overall symptom severity, overall improvement in health-related quality of life compared to omalizumab. The peak nasal inspiratory flow was significantly improved in dupilumab versus omalizumab in these patients, and then overall severity of their chronic rhinosinusitis. And then in terms of emerging therapies, things that are not yet FDA approved for treatment of chronic rhinosinusitis with nasal polyps, there's a study of tezepelumab versus placebo in patients with CRS with NP, and we see that it led to substantial reductions in the nasal polyp size over 52 weeks of treatment, as well as reduction in the patient's mean nasal congestion score compared to placebo. And other emerging therapies to kind of think about, depemokimab, which we talked briefly about. It's an ultra long-acting anti-IL-5 that's dosed twice per year every 26 weeks. And the phase 3 Anchor 1 and Anchor 2 studies did show that there was a statistically significant improvement in the co-primary endpoints, which were the total nasal polyp score and the mean nasal obstruction verbal response scale score in patients who used depemokimab versus placebo. It was quite well tolerated. So next, we're going to talk about navigating biologic options and monitoring strategies.
So, Katie, we had a question that came in, and I want to ask you the question. Patients often ask about the side effects and long-term safety of biologics. They are also inquire about the likelihood of symptom relief and how long before they might notice improvement, and the necessity of ongoing use. I think that's probably one of the most common questions that I get in my office. How would you answer this question?
Yeah, this is a great question. So the good news is, I think with more and more patients being on biologics for a variety of indications, we're learning a lot more about kind of the long-term safety profile. So, in general, I tell my patients that most patients tolerate these very well without a problem. And we talk about, some of the really common side effects like injection site reactions. And then for each specific biologic, there are, I think, some uncommon things that we see that I warn patients about. I'll often, provide to them the package insert so that they can read about it on their own too, if they want to. But we discuss, things to look out for, things that they should let me know about. And also that if something changes or there's something unusual they notice, they can certainly, contact our office, give us a call and talk to us about it. So generally we provide a lot of reassurance, but kind of some important information about unusual things to look out for. And then, I get asked this question too, like, um, how quickly is it going to work? What am I gonna experience? What should I expect? And I think what we tell patients is for some patients, we see that their symptoms improve quickly. That sometimes within weeks they notice that they can start to smell again or feel less congested, feel better. For other patients, it might take a little bit longer. So we usually give a good 6-month trial before we call a biologic, failure, say that, hey, it's not really substantially improving symptoms. So I think setting expectations that there's variability can be helpful for
Yeah,
patients.
those are great. That's great. Great insight. Another question, should surgery be done before initiation of biologic or after?
Yeah, that's a great question. I mean, generally, generally we're starting biologic, especially for nasal polyps, in patients who've had surgery and they've had at least some recurrence or their symptoms are starting to deteriorate and we're thinking that they're having recurrence or that their disease is not controlled. But I think that this is really an interesting area of investigation. I'd love to hear kind of what you're thinking from the otolaryngology perspective.
Yeah, I think most otolaryngologists would say that a biologic should be started after surgery. So, so to see if the polyps are going to come back after the surgery, because we know, as you've seen in the papers and the slides that we discussed, about 50% of people actually do okay with surgery with topical steroids, and so that's why most of the otolaryngologists would like to do it after. But certainly there are some patients who don't want surgery, so you may need to start it before.
Yeah. Another exception that we see to starting it after surgery is, in patients with severe asthma who need to be on biologic for asthma, we'll start the biologic therapy, sometimes see if we can get adequate control of their upper airway disease. But if not, there are patients who, need to be on the biologic for asthma and still may go on to have sinus surgery. So that is another kind of area where we'll sometimes start biologic therapy first.
And actually, I think the next question is from a poly ENT doctor, which is, what about the combined use of biologic and surgery?
Yeah. So, I mean, I think this is a great ENT question. I will tell you from an anecdotal perspective, I've had patients who've done this, and I think there are, certainly studies looking at it, but I think that there is a lot more we need to learn about using biologic therapy and
Yeah,
surgery
and I
together.
think that's the most common, some of the most common or the most interesting topic that otolaryngologists are looking at, and people are doing studies on, and hopefully we'll get a little bit more insight into that. If a patient is doing well on a biologic treatment, is it appropriate to consider decreasing the dosing frequency?
Yeah, so this is, I think, another really area where we're learning a lot in the real world about sort of appropriately tapering biologic therapy in some patients who are interested in doing so. There was data actually from the phase 3 study specifically of dupilumab for treatment of nasal polyps showing that a lot of patients did well on, instead of every 2-week dosing, every 4-week dosing. And there are now real world studies showing that there are patients who do great on less frequent dosing of dupilumab specifically. So that is something that we are offering to our patients. And the question that I usually ask to decide whether or not to initiate this is, at the end of the 2-week dosing interval, are you starting to feel congested again? Do you feel like you're losing your sense of smell again? Are you really looking forward to your next dose? And if I have a patient who says, no, I actually just feel great all the time, sometimes we'll think about tapering their dose. at that juncture.
Yeah, and I have similar patients like you have had and you've described. The issue in the U.S. is that if the patient starts decreasing the frequency or increasing the interval between the dosing, um, and the insurance, the payers see it, sometimes it becomes an issue, and so I've been. You know, in the U.S. especially, been telling the patients to make sure you get refill um, the the frequency of the biologic as indicated for the nasal polyp, so that they are no longer they are able to continue using the biologic. Because one of the things that I've seen is that patients, when they start doing well, they start increasing the frequency, and then the payers come back to the patient and say, since you're feeling better, we are no longer going to cover the biologic. And I'm not sure if you had a similar situation.
Yeah, that is a really frustrating problem. I will say that I explained to patients that this would be an off-label dosing regimen. This is not, following the label, and that, if we will often um, issue a new prescription with the less frequent dose if the patient when I have the patient first try it, I say, keep filling it, because you might want to go back to the initial dose. But if the patient does well and is like, no, I want to stay on a less frequent dose, we'll write a new prescription. And I would say that overall we're actually being able to get that covered for most folks. But I think that's a really important thing to warn the patient about and have them let you know right away as soon as there's a
Yeah,
potential problem.
great. And the last question, how do you approach the management of patients who are partial responders or non-responders to biologic?
Yeah, so this is really hard. Um, I think in folks who have some partial response, we really want to, I think, lean into our otolaryngology colleagues, make sure the patient gets back over to see their ENT doctor, because I think there are patients who have some improvement, but they may have some, anatomic problem, maybe some scarring or something else related to a prior surgery, where they have some resolution of symptoms related to the biologic, but may still need to have a revision surgery. So that's something that I always try to make sure that the patients that I'm following are followed closely by their ENTs and having, follow-up nasal endoscopy to look for any abnormalities. For patients who are non-responders, this is not that common, but it is a huge disappointment when it happens. And for those folks, again, we, consider whether or not it makes sense to switch biologic therapy. We think kind of about what might be driving their disease, information about their biomarkers and potential endotype, or whether it makes sense for them to, see NT and have revision surgery at that time.
Yeah, and I think this is where the multidisciplinary approach is so vital, because if patients are saying they're not feeling well with the biologic for their nasal polyp, the next question is, well, how is the biologic treating your asthma, and is your asthma well controlled, and what did your allergist, immunologist, or pulmonologist say about your asthma, and if they say that the asthma is well controlled, and they don't want me to change it, that's where I talk to the patient and kind of talk about different options, such as doing the surgery while they keep the same biologic which improve their asthma, or do I need to talk to the specialist about changing the biologic? And so that is a decision I don't make by myself. I definitely involve the specialist that also takes care of the lower respiratory disease. I think it's important, as you heard earlier, to talk about the expectations, because the expectation sets the rule for what the patients are going to expect and see if the treatment is a failure or not. And so you want to sometimes tell them, the improvements can happen as early as 2 to 4 weeks. Sometimes some of the symptoms can last a little bit long, may take a little bit longer to get improvement on. Certain biologics are a little bit faster than others. So those are things that you want the patients to kind of continue to use the treatment. As you heard earlier, we like to reassess the patient at 3 months and 6 months. And at 6 months is where we started talking about, is it working or not working? Because as we mentioned earlier, some of the biologics may take a little bit longer to work. And I think, answering questions about, the use of biologic in surgery, I think, are things that we do want to talk about. And one of the questions that patients who decide to get a biologic is, how long do we need to be on the biologic? And so let me cover some of those topics. At 6 months, you want to assess whether the patients are doing better. And the different criteria that we use are: has the polyp size improved? Have they gotten smaller? Have they reduced the need for systemic steroids? And some patients, we always talk about patients who are steroid dependent. We also have patients with nasal polyp that are also steroid dependent as well. And so we want to reduce the need for systemic steroids. Has their quality of life, such as congestion, improvement of smell, and ability to sleep, important? And we assess that at 6 months. And if we feel like they're doing well, we continue it. If not, we can talk to the patient about whether or not we want to continue it for another 6 months, or decide different treatment options. And so here is a definition of what we mean by postural responders and non-responders. And in the previous slide, you also saw in that paper, we also saw, like, how many of the criteria that they meet to be described as a partial responder or non-responder. And after they are, if they're a partial responder, certainly we would consider the therapy and monitor them. If they're non-responder, that's where we have the discussion of biologic switching or surgical intervention. So one of the things that you heard earlier was a question on the frequency of the interval of the different biologic. And this was a really nice paper from Brigham. And I think, Katie, I'm going to turn it to you to see if you want to talk about the slide.
Yeah, sure. I'm happy to. Thank you. So we have a large registry of patients with ERD or NZ-ERD that we follow longitudinally. And we sent out a survey to our patients. And we asked the question, like, are you on dupilumab? And in the patients who are on dupilumab, we asked them, have you attempted dosing intervals other than every 2 weeks, and kind of what worked for you? Where did you land? And we found that we had many patients who were actually dosing. About 2/3 of the patients were taking dupilumab specifically. Just that's the only question, or the only biologic that we asked about in this particular survey, less frequently than every 2 weeks. And there were patients who were taking it every 3 weeks in orange, every 4 weeks in green, and between every 4 to 8 weeks in purple. So a lot of patients who were dosing it less frequently. The opposite of that is that there are also patients who took it more than every 2 weeks. So there are some patients that we follow who felt like every 2 week dosing just wasn't enough and they wanted it more frequently, but the majority of them actually were taking it less often.
I think it's important to look at these patients, and you see from the slides that a third of the patients with nasal polyp with comorbid ARD did have a different frequency of dosing based on the initial label of the dupilumab. And so, I think this was such a great study that you did. And I was wondering how we were going to perform similar information in the US that was replicated in Europe. Because in the US, the dosing frequency and following the label of the biologic is so important. But in Europe, it's a little bit different. And so this is a study from Amsterdam where they also looked at dupilumab in patients with nasal polyp. And in Europe, what they were able to do was able to strategically increase the interval of the dosing for dupilumab. So a lot of the patients were started on getting it every 2 weeks for the first 6 months. And then after that, based on the response, some of these patients, the interval of the dosing were increased, and some of the patients were getting it every from 2 weeks to 4 weeks, and then they went to 8 weeks, and then 12 weeks was the longest. And what we saw was that despite that the patients had increasing dosing after 6 months of dupilumab for patients with nasal polyp, these patients continue to have good control, meaning that the patient's symptoms were well controlled. And then when we looked at the response, who were responders and not responders, you could see that even those patients, after 6 months of getting it dupilumab for 2 weeks, and when we followed them, even with the increasing interval of injections of the dupilumab, that these patients still did very well. And so I think, the study that you guys did at Brigham was such an excellent paper describing what the Europeans did and showed that even though even though you may need to be on a biologic based on the label frequency initially, as the patient's symptoms improve, we can maybe continue to we can increase the interval between the dosing and still have good control of the patient's symptoms as well as a good response. And this is looking at the different, they were tapering the use of dupilumab, and you can see that based on objective smell test, which is a sniffing stick test. And we do think that sniffing stick test is a better measure because it's a three-dimensional way to evaluate smell. Upset is a really easy one. Sniffing stick is a little bit more complex, but more three-dimensional way of developing a smell. And you can see that even when they tapered the dose of dupilumab, they were able to continue to improve their sense of smell for a long time. We see that there's a reduction in the SNOT-22, and even with tapering the dupilumab, that they still had good control as evaluated by SNOT-22, and you saw that there's an improvement in the nasal polyp score, and it continued to have good result with the nasal polyp score. And one of the questions that was asked was, if we stop the biologic, will the patient have persistent improvement? And this is a study from Synapse looking at mepolizumab. And so these were patients who were given mepolizumab for 52 weeks. And at week 52, we stopped the mepolizumab. You see here in the slide, even though the biologic was stopped, this patient continued to have improvement in their blood eosinophils and also improvement in nasal symptoms. So this is where there's a little bit of a sustained effect when using a biologic and then stopping it after a year. So this was a study that was done in Montreal where they used perioperative dupilumab around the time of surgery. And what they wanted to do was, evaluate, does the perioperative use of biologic around the time of the surgery affect the results of the surgery? And what we see here and this is a study design, so there was a little bit of a run-in period with the use of nasal steroid spray. Then one group got dupilumab around the time of the surgery. Another group got the placebo group. And then after the surgery, these patients were followed up. And what we see from the results is that the results were very similar between the dupilumab group and those who did not. That we see that after the surgery, those who received biologics as dupilumab and those who didn't have actually had similar results. The only time where the biologics seem to do a little bit better is in the sense of smell, that they certainly did do better. So I think these are studies that I think that are going to occur more and more, and from that, hopefully we'll be able to better answer the question, can we use these biologics around the time of surgery, and what will be the effect? And this is only one study looking at dupilumab. There is another study looking at the perioperative use of mepolizumab during surgery. In summary, from the slides, we learned that chronic sinusitis with nasal polyp is a chronic type 2 inflammatory disease leading to symptoms of nasal congestion, facial pressure, loss of smell, and polyp formation. Certainly, there are several biologics that are approved for patients with nasal polyp, and offering these biologic therapy as a targeted precision treatment for patients with uncontrolled nasal polyp is helpful in decreasing the relapse of nasal polyp and the symptoms. Certainly, comorbidity is a factor. When using biologics on patients with nasal polyp, it reduces the nasal polyp size, improves patient symptoms such as nasal congestion, loss of smell, and also potentially reduces the need for surgery. I think shared decision-making process and setting realistic goals are crucial in offering biologics to these patients with recalcitrant or uncontrolled CRS with nasal polyp. And I think incorporating a shared decision-making process improves the adherence to the treatment plan. So thank you for joining us today, and thank you, Dr. Bakite, for providing her insights to the discussion. We hope that you found this activity to be useful in your practice.
Yeah, thank you so much. That was a fun discussion.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This program is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/FVW860.